Hello, my name is Sandra Finestone. I'm here today to talk to you about peer support services to address the health and wellness of people living with mental health challenges. Today's program was developed by a dissemination team comprised of leaders from the Chicago Health Disparities Center at the Illinois Institute of Technology and the International Association of Peer Supporters, also known as INAPS. The Chicago Health Disparities Center is a group of investigators and persons with lived experiences that examine the health and wellness needs of people with serious mental health challenges. The team also examines the barriers caused by public stigma and self-stigma. The ultimate goal of the center is to improve the quality of health while simultaneously eliminating the effects of stigma on health conditions for persons with lived experience. Serious mental health challenges are defined as mental health concerns that hinder the individuals from achieving their specified life goals. INAPS is an international organization whose mission is to grow the peer support profession by promoting the inclusion of peer specialists throughout healthcare and other community systems worldwide. We're here to talk to you about the impact which peer support services have on the health and wellness needs of people living with mental health challenges. The presentation is based on a view of hope and recovery. Consider what Christian Larson said: believe in yourself and all that you are. Know that there is something inside you that is greater than any obstacle. I first became interested in the issue of mental health challenges when I was diagnosed with breast cancer and saw the emotional devastation that diagnosis caused not only for patients but for their families. I became a peer counselor and a mentor for women in my community. I went back to school, got my doctorate in psychology, and began working at a cancer center where I was able to extend my outreach. I presented about mental health issues and cancer locally, nationally, and internationally. I currently sit on the Orange County Mental Health Board and also two Medicaid committees, as well as advocate roles on the FDA, NCI, NIH, DOD, and PCORI. I am a caregiver for a cousin who is developmentally challenged and a nephew who has paranoid schizophrenia. I also have a private practice for cancer patients, and I facilitate several support groups. I have nothing to disclose, and I have no conflicts of interest. This presentation will review the value of peer support providers in assisting people living with serious mental health challenges and attaining their health and also their wellness goals. The statements presented in this work are solely the responsibility of the authors and do not necessarily represent the views of Patient-Centered Outcome Research Institute, also known as PCORI, its Board of Governors, or Methodology Committee. For those of you who don't know about PCORI, it funds comparative clinical effectiveness research that engages patients and other stakeholders throughout the research process. It also seeks answers to real-world questions about what works best for patients based on their circumstance and, of course, concerns. PCORI's mission currently is about people living with serious mental health challenges, how they get sick and die 10 to 20 years earlier than the same age peers. This pattern is even worse if the person is of color or from low-income communities. Peer support services are one way to assist this group in achieving specified health and wellness goals. These kinds of physical illnesses left untreated can cause negative results. People living with mental health challenges use the emergency room more than the same age peers for their physical health problems. They become disabled, limited mobility along with the inability to meet personal goals related to education, work, or independent living because of these physical illnesses. They often end up in institutions. There are state hospitals, but many people end up, unfortunately, in nursing homes, 24-hour care centers, where people get the care needed that they cannot provide for themselves. Unfortunately, they die 10 to 20 years younger than other people, and this is unnecessary. What makes their health worse? The problem of illness and death among people living with mental illness is worsened by several things. People of color with serious mental illnesses are likely to show worse patterns of sickness and death. People who are poor have worse health, especially if they're homeless. Crime worsens health. Crime victims get sick more often, but so does the victimizer, especially when caught by the criminal justice system and maybe ends up in jail or even worse, prison. Crime also includes substance use. Excessive use of alcohol and other drugs worsens the pattern of sickness and of death. How does this occur? There exist many reasons why mental health worsens health. We will examine 3 here. First are social determinants that affect health. These are typically modified health or behavior risks that make health worse. For example, because of life events, some people have poor diets. They have little exercise, they smoke, they engage in survival sex practices, or self-medicate with harmful substances. These are meant to be a list of behaviors which people can learn to manage if they so choose. We also operate in a fragmented health system. Sometimes health and wellness are lacking because the community lacks the kind of resources it needs to provide quality care. This is the 3rd reason for bad health. Those clinics that are available cannot be easily accessed. They are in parts of town where transportation is missing. Entitlements are insurance coverages. Public insurance is often lacking for available services, so patients cannot pay for care. Parity in insurance is equal pay for physical health and mental health care. Parity is often lacking, so the quality of mental health care lags behind physical care. Together, these problems describe the fragmented system that I referred to. And now we're in the middle of the COVID pandemic. What is COVID-19? Well, we know that COVID-19 is a viral infection that causes respiratory illness that, when severe, can lead to death. People all across the United States have had to institute precautions to keep from being infected by this disease. This includes sheltering in place, maintaining 6 feet social distance, and wearing masks in public. If a person believes they are infected, they should promptly be treated from a qualified medical professional. If they're positive for the infection, they should then receive treatment from the medical profession. Sheltering in place has led to significant stress and social isolation, which may worsen the mental health of people already vulnerable to psychiatric illness. So peer support services can be one solution. We just reviewed the size of the concerns related to physical health and those living with mental health conditions. Let's now consider solutions. Specifically, let's look at the benefits of peer support. As we said earlier, peer support providers are peers who help patients accomplish their health and wellness goals in the communities in which. Community health workers often advocate for patients in situations where healthcare providers are falling short. They may educate patients about symptoms, about illness, about treatment, and they'll help them deal with those symptoms and those illnesses. They empower, they support, they advocate, and they educate. Peer support specialists are another support service that can be utilized. Patient navigators provide peer support, which has become a prominent vision and resource for mental health care services. People with lived experiences, by virtue of their shared experience, can be vital agents of help. They may do this in mutual help groups. These kinds of groups are often called self-help groups. They are patient-run organizations which participants gain empowerment and better health outcomes. Self-help groups have been active for more than 50 years. Mutual help is a better term, perhaps. Namely, it benefits both individuals living with serious mental illness and the individual in recovery consistently achieve self-determination goals. Basic values of peer support include accepting, empowering, goals focusing, and the fact that they are in the community. Several values define the peer support specialist. They are recovery focused. Namely, they are hopeful and supportive of personal aspirations. As a result, they are very accepting. They have no strings attached to their services, nor do they impose expectations. They promote empowerment in their life in general, and more specifically in regard to their health decisions. As such, they are very, very goal-focused. They help patients identify what they want to do differently in terms of their health and in terms of their wellness. And it's important to note that all of these services are provided in the community in which they live. So what specifically do peer support specialists do? Programs that have used peer support specialists do three things in terms of a person's health and wellness. First is shared decision making, to engage the person in considering treatment options and choosing those options that best meet their personal goals. Second is to teach skills and provide concrete information and behavior that helps people manage their health and their wellness goals. Third is to navigate the system. Peer support specialists walk the patient around a very complex healthcare system. And they promote shared decision making. Shared decision making is not specific to mental health. It had first become the standard of healthcare in general, and it evolved into the mental health arena. It involves three steps. First, the healthcare provider helps patients fully understand their health and wellness goals. For example, how harmful are specific symptoms? Self-management should be encouraged and engaged in order to promote self-determination. People should be supported to make decisions they make about their health and wellness, as well as the steps they take to address these decisions. People need three things to realize self-management: information, behaviors, and opportunity. Peer support specialists provide basic down-to-earth services to help patients deal with this fragmented system. They help people review different options for services, where they're located, perhaps if they're culturally relevant. These choices are often influenced by the type of insurance that a clinic takes. Peer support specialists help the person contact the clinic to find out what insurances they have before arriving. They help people make appointments that are convenient to that patient. They then accompany patient often to the appointments. This typically includes public transportation, so the peer support specialist works with a person to map out the easiest route to the clinic. Peer services may have an important role during the COVID pandemic. Most likely their work will be done virtually. Peer supporters should encourage people to shelter in place as recommended by the local public health authorities. People should regularly check for increased body temperatures or respiratory problems. and seek out COVID testing if they think they need to be tested. Peer service providers should also be sensitive to worse mental symptoms among people who they serve to help them engage where they're needed to manage that stress and isolation. We did a careful review of PCORI database to identify all studies PCORI has supported related to paraprofessional support services. These 7 are related broadly to programs that address the health and wellness needs of people living with mental health challenges. Some of these studies have been completed while others are still ongoing. Today we will summarize what has been found in 3 of these completed studies. The first PCORI-funded study we will review was conducted by John Breck from the University of Southern California, titled, "Can People with Serious Mental Health Illness Help Peers Manage Their Health Care?" This project tests the BRIDGE program in comparison with treatment and usual services. The BRIDGE program seeks to improve healthcare access, utilization, and its impact on self-confidence in managing one's overall health concerns. BRIDGE did this by having peers, people in recovery from mental health illness, teach research participants health management skills. The BRIDGE program has a manual that was used to implement the interventions. The intervention is augmented by motivational interviewing, education about illness, modeling skills, and practicing the new skills through the assistance of the paraprofessional. In the research evaluation of the program, 151 people with serious mental illness were randomized to mental health care as usual, which is called the control group, or BRIDGE, plus mental health care as usual. Data was collected at baseline, 6 months, and at 12 months. The research team collected 3 sets of measures. First was the health services, measured as the number of routine health care visits, number of routine health screenings, and participants' perception of their relationship with their healthcare provider. The second measure was confidence in self-measurement was assessed by asking participants to report their sense of confidence in making decisions about their health and their healthcare needs. Third, 2 sets of healthcare concerns were assessed. Chronic illness being the degree to which research participants were concerned about ongoing and persistent physical illness, and their overall perception of bodily pain. Data presented in the next 3 slides represent changes from baseline to 6 months reported by research participants in the BRIDGE group versus the control. Findings here are reported as change scores by subtracting person's score at baseline from the report at 6 months. Note that a significant improvement was found for the number of routine visits and the number of routine screenings from baseline to 6 months. The quality of relationship measures is reverse scored, such that more negative scores from baseline to 6 months actually represents improvement in perceived relationship. Findings in this graph show that in the BRIDGE group, participants in the BRIDGE group have a better relationship than those at the control group, although this difference is not significant. This graph shows changes in perceived confidence in managing one's health care. Note that there was a significant improvement for people in the BRIDGE group, while those in the control group actually showed worse confidence. This research was done in a partnership between the University of Southern California Social Work and the Pacific Clinics. If you want more information, please go to this website to learn more about their health navigation training program. The second PCORI-funded study was conducted by Dr. Patrick Corrigan from the Illinois Institute of Technology, titled Peer Navigator Support for Latinx patients with serious mental illness. In an effort to be transparent, Dr. Corrigan is also the principal investigator of the overall disseminated group supporting my presentation today. Dr. Corrigan's study developed a peer navigator program called PNP using community-based participatory research, CBPR. Peer services provided were Latinx or Latinas in recovery and those living with serious mental health challenges. They helped research participants to better engage in health services. In the process, research participants were expected to better address their own health goals. The key element of the PNP was to literally walk the service recipient around the complex and fragmented healthcare system. 110 Latinx with serious mental illness and physical health concerns were randomized to peer navigation programs or to integrated care only, ICAU. Data was collected baseline at 4, 8, and 12 months. This graph examines how monthly achieved appointments changed over the 12 months of this study. Scores were adjusted by age and place of birth of research participants. By place of birth, we mean whether the individual participants were born within the United States or in another country. Results showed a significant interaction, which suggests a steady increase in achieved appointments for peer navigators compared to the control group. This finding shows a clear interaction with steady improvement in self-reported recovery for those in the peer navigator group compared to the control group. This last graph shows changes in quality of life baseline to 12 months. Once again, steady and significant improvement is seen in the peer navigator group, while quality of life in the control group unfortunately did not change. This research was done as a partnership between the Chicago Health Disparities Center at the Illinois Institute of Technology and the Triology Behavioral Health. If you would like more information about this study, go to this website to learn about that health navigation training program mentioned in this study. The last PCORI-funded study was led by Crisal Bellamy from Yale University and was titled, "Does a Peer-Led Program with Wellness Coaching Improve Wellness Among People with Serious Mental Illness?" Using community-based participatory research, this group developed the Peer-Led Wellness Coaching Program. Wellness coaching was a six-month program and included 3 months of peer-led groups educating participants on personal wellness, stigma, and self-management strategies. In addition, program participants received 6 months of individual wellness coaching offered by a peer provider. 74 people with serious mental illness entered into this program. Defined quasi-random design, same place definition here. 37 were assigned to wellness coaching and their scores were compared to 37 others with serious mental illness who received treatment as usual. Data was collected at baseline, 4, 8, and 12 months. 5 sets of measures were collected in this study. First was the number of emergency room visits. Next, did the participant report any changes in alcohol use? General wellness measured how participants perceive their overall wellness. And did participants report greater input and decision-making into their treatment plans? Finally, did they report greater satisfaction with treatment? This group does not represent exact data, but demonstrates the general trends between the two groups. Compared with participants who received usual care, participants in the program showed fewer psychiatric or substance use emergency room visits, greater decrease in alcohol use, greater improvement in general wellness, more treatment plan input, and greater treatment satisfaction. If you would like any information about the information presented in this presentation, you can contact Dr. Corrigan at the address shown here. This is the end of our presentation. Thank you for your time. And as I mentioned, you can learn more about the studies that were done, the peer support programs that we talked about, by visiting the website of CHDC or INAPS. And I also encourage you to email Dr. Corrigan if you have any questions. He'd be more than happy to answer any questions that you may have. Thank you for your time and interest.